So, good evening, everyone present here. I thank our senior faculty, Dr. Ruksheda ma'am, Dr. Smita Deshpande sir, ma'am, sorry, and Dr. Laxmikant Rathi sir, and also Dr. YC Reddy sir for joining and making this 8th webinar on the OCD clinics possible today. I would like to invite my co-chairperson for this case walk series and the YPS subcommittee, Dr. Nihal, Dr. Nihal, to please introduce our guest of honor for today's webinar.
It is a great pleasure and honor that I would like to introduce Dr. Laxmikant Rathi, sir, our guest of honor to our case box series. Sir is a distinct consultant psychiatrist with an illustrious career spanning an impressive 42 years at Govardhan Hospital. Sir is currently the Vice President and the President-elect of Indian Psychiatric Society. Sir's dedication in IPS is exemplified by his roles as past President of IPS West Zone and IPS Maharashtra. And Sir is not only a leader in professional organization, but also has been the founder president of VPA and Amravati Psychiatric Society. His commitment is evident through his past roles as a direct council member of IPS, an EC member of IAPP, and a past president of IMA Amravati. In addition to his outstanding contributions, Sir has also played a pivotal role in the community service. Sir served as a district governor of Lions Club International in 2007 and 2008, and later as past multiple council chairperson of Lions Club International in 2008 and 9. We are privileged to have you, sir, as our esteemed chief guest of honor for this today's webinar, and we request you to speak a few words from your wealth of experience and expertise to our young psychiatrists.
Good evening, everybody. At the outset, I thank you, Dr. Nihal, very good and brief introduction. Indian Psychiatric Society National Young Psychiatrist Subcommittee is always an asset to IPS. I have no hesitation in saying so, that as far as my experience, probably you are the best committee who work in all the directions, especially in taking physical meetings as well as webinars. I will give a big round of applause from my side as the president-elect for your wonderful work. Unfortunately, I was not able to attend your some physical meetings as well as in future also, but you do an excellent job. Carry on this. You have to carry on this good job in future also. As far as today's webinar is concerned, you have told it is the 8th webinar, and we have got eminent speakers like Dr. Sreya, Dr. YC Janardhan Reddy, who has done a wonderful work. I myself heard him in few conferences when I was canvassing for my post as well as in conferences. Chairpersons under whom the committee is working very well, Dr. Ruksheda, Dr. Smita, and the wonderful, I am audible, no?
Yes, sir, you're audible, sir.
And the wonderful work, the person who introduced me just now, really young psychiatrists who have got a great passion for Nihal, Samiksha, as well as Kashyapi also, who are wonderfully working for this subcommittee. As far as coming to today's topic, OCD. OCD is such a disease that it is very much prevalent in the society. But very few people come to us for the treatment. What is the reason? Reason is lack of awareness. Many people think, कुछ लोग सोचते हैं इसकी आदत हो गई है, अब ये शायद नहीं बदलेगी. Many people think that maybe she is having an extra cleaning effect, so उसको नजरअंदाज किया जाए. And by the time they reach to us, probably their disease has progressed a lot. So one thing I would like to tell, especially these young psychiatrists, that these people, I always say something, and these things from every forum where I get a chance, that we have definitely to increase the public education and awareness. And it is as such very near to my heart. And I feel that if we are able to increase that public education and awareness, not only about the OCD, about all the neurotic illnesses especially, because I always say, we have played our career, but you young psychiatrists have got a very wide future. There is a much of the iceberg below which you have to treat, because all the other specialties, I have never hesitation in saying whether they are cardiologists or they are neurologists or they are pediatricians, they are eating much cake of our field. Recently, I can nominate so many diseases. Now, let us coming to this topic of concerned neurosis. I feel that treatment modalities as well as the counseling, both has got a very good role in this counseling. Secondly, in my experience of 42 years of practice, I must have seen hundreds and hundreds of OCD patients. very much think one thing जो उन्हें समझा दिया जाना चाहिए या उनके relatives को that this person is not at fault. Usually what happens, the people think that this person is at fault. It is just a habituation. As a consulting psychiatrist, it is our duty and responsibility to tell the relatives that it is not habituation. It is a disease which is because of some chemical disturbances. And that time, the patient is also relieved to the some extent, and probably the aspects of the relatives also they change towards this. Secondly, I would say this is a disease where cocktails work. Don't take me otherwise. I'm not talking about alcohol, but I have seen any other diseases. This is the only disease where speakers are also there who will tell you. I'm not a academician, but I tell you, mixing something in a low dose works in OCD very much. Whether it may depend on your experience or probably on your these results which you get in clinical practice. Sometimes risperidone here and there, sometimes any other drugs, basic drugs you are all aware of. The speakers will definitely talk of this. I would not like to take much of a time. This is an interesting topic, and this will remain interesting always because this is a very common thing. I'm happy that you have taken a webinar on this. I'm thankful to the Young Psychiatrist Committee for the love and affection you have always shown to me. And I would request, I'm thankful to you for all that. And I will request now to proceed with the scientific sessions, please. Thank you very much.
Thank you, sir. Thank you very much. Now I would like to request Kashyapi to introduce our first chairperson of the day.
So it's my immense pleasure to introduce Dr. Ruksheda Syeda ma'am. She is a psychiatrist and a psychotherapist working at the Trellis Family Center in the Lokhandwala, Mumbai. And she has the specialties of adolescents, young adults, and women and families. She is the current president-elect of the Bombay Psychiatric Society, and she is also the vice president of the Indian Association of Biological Psychiatry. She is currently the co-chair of the Women and Mental Health of the Indian Psychiatric Society, and she is the advisor in the Led by Foundation at the Family First Guidance Center. She did her MBBS from Lokmanya Tilak Municipal Medical College and Hospital, Mumbai, and she completed her MD from GS Medical College and KEM Hospital, Mumbai. She also has a WHO fellowship in the psychosocial rehabilitation from South Korea, and she has given multiple TEDx speeches, and she is an expert in media. And her passion project is the YAMI. It's a support group for young adults, which is held monthly. And the fun fact about ma'am is she loves to laugh and can sing and won't cook. So welcome, ma'am, to this Casebox series of OCD. And I would like you to introduce speaker one, the young psychiatrist for this evening.
Thank you so much, Kashyapi. That's very, very kind of you and sweet of you. And I always love when people include my fun facts in the CVs because nobody reads it out otherwise. Thank you so much, Dr. Rathi, for joining us today. And it's always a pleasure to have you there. And it's an honor for us to be that you've chosen to grace the occasion today. And it's especially delightful for me to not just share the session today, but also introduce our young colleague. When I was, sharing this poster on my Insta story, that's what I wrote, that, showing up for young colleagues, but learning from them as well. And who better than Dr. Sreya to speak to us today? She's an immensely talented young woman, currently serving as a senior resident at the GMC Manjeri, where she's, I'm sure, a delight to patients and, admired by her juniors. And I'm sure that she's doing a great job and is recognized by her seniors as well. Her interest in academics is reflected that she's been the peer review for IJP and the Indian Journal of Psychological Medicine. She's been an assistant editor for the Indian Journal of Psychological Medicine. We know she's an artist because she's also been an illustrator for the Indian Journal of Psychological Medicine. We know that she's won a lot of awards. whether that's write a book review, whether that's a PG project, a research project. And of course, we also now hear more about her interest in gender equity and, work in women's mental health, where she's worked with various organizations like Haiku and Aham, where they've talked about menstrual taboo and, for the LGBT-friendly campuses. So it's really a pleasure to invite her today to share her learnings, and so that we may learn more about OCD from her as well. And it's been an honor for me to introduce her, and hopefully we can stay in touch even after today. Thank you so much for that. And with this, I'm going to hand it over back to Kashyapi.
Thank you, ma'am. So I would like Shreya to please continue with and start with her case presentation of the evening.
Is my screen visible?
Yes.
Yes, it is good.
Yes, I hope this is visible, right?
Yeah.
Yes, we can hear you.
Yeah, thank you. So, good evening, everyone. I'm presenting the case of an 18-year-old BA student belonging to a middle-class socioeconomic status Hindu family. At the time of presentation, he was living with his maternal grandparents, mother, and younger sister. There is nil significant past history. Family history revealed a history of alleged suicide in his father 6 months back following a financial stressor. Pre-morbidly, he was described to be a person who had easy temperament. He presented to us with recurrent intrusive thoughts of 5 years duration. For the last 2 years, he had been feeling anxious always. Can I continue?
Can I please request everyone to mute themselves, and for the host to mute the people who haven't muted themselves?
Could everyone please mute yourselves? Nihal, could you? Thank you.
Yes, do it.
So he presented to us with recurrent intrusive thoughts of 5 years duration. He was always feeling anxious, as well as there was excessive fear of being judged for the last 2 years. We probed into the history of present illness. He was quite well adjusted until 13 years of age. Right from the early adolescence onwards, he had frequent masturbation, and sometimes there were guilt-inducing fantasies about his female relatives. But it was from almost 13 years of age that he had these recurrent intrusive thoughts that persisted despite efforts to resist. Initially, they were related to contamination and were accompanied by repeated washing. But then later, he started having thoughts and images of sexual content. For example, whenever he did something, naked images of his mother, sister, and female relatives would come into his mind. Sometimes there were quite intrusive doubts about impregnating them. Sometimes there were quite distressing images regarding body secretions like blood, phlegm, anus, and such distressing images would come into his mind. So he described them as quite distressing. He felt quite guilty and distressed whenever these thoughts came into his mind. He described these as the most worst feelings in the world. And he would try to distract himself with movies and music whenever these thoughts occurred. However, there is no history of any neutralizing behavior or any repeated motor acts or mental acts in response to these thoughts. For the last 2 years, he also reported feeling quite anxious and worried on most of the days. He would feel tensed, keyed up, have difficulty concentrating, mind going blank, sleep difficulty. There was also excessive anxiety and fear in social situations. This was mainly related to the fear of being judged and negatively evaluated. As a result of this, he was avoiding activities at college as well as family functions. So we went through his treatment records. We found that he sought treatment for the first time 2 years after the onset of illness. By a private psychiatrist, he had been given fluoxamine as well as fluoxetine, both of which he had received an adequate dose as well as an adequate duration. He had also received augmentation with lithium as well as some sessions of CBT. Yet he had no improvement. So we did a mental status examination. The thought content revealed multiple preoccupying worries. Also, there were multiple obsessions. Mainly, there were naked images of his female relatives, distressing images of body secretions, and intrusive doubts about impregnating women. His mood was anxious. There were no other positive findings in the mental status examination or the physical examination. So, according to DSM-5 as well as ICD-11, we arrived at a diagnosis of obsessive compulsive disorder with good to fair insight, generalized anxiety disorder, and social anxiety disorder. We did a Vibox scale. The score was 23. Vibox symptom checklist was also done, and we found that the most distressing obsession was sexualized images. So he was already on fluoxetine and lithium when he came to us. We added clomipramine, the dose of which was gradually increased to 125 milligram. We added risperidone 2 milligram as an augmentation. And also, as he had difficulty sleeping at night, we added a small dose of clonazepam as well. During his stay in hospital, we did intensive daily basis CBT for the patient. So our patient had a habit of writing down diaries multiple times a day. Whenever these thoughts occurred to him, he would jot down these thoughts every day. So every day he would present us with about 30 to 40 pages of these thoughts. So this contained a wealth of information. However, it was quite difficult to extract the information from it and know which all thoughts were troubling him. So one of the first things which we did was structure this habit of diary writing into a thought diary so that we can identify what his dysfunctional thoughts were. We extrapolated the thoughts that we identified from these self-monitoring diaries as well as from many open questions that we asked during his interviews into the cognitive model of OCD. So here is the cognitive model of OCD. There are normally occurring intrusive ideas, images, impulses, doubts, etc. In the presence of some faulty cognitive appraisals, they will be resulting in obsessional anxiety. When the person has active resistance to these thoughts or avoidance, this will lead to increase of all these symptoms. So in our case, from the diaries as well as the open questions, we could identify, hello? Okay, we could identify some cognitive appraisals. Also, multiple times whenever these thoughts occurred, he was trying to control them or suppress them, which was in turn leading to increase of these symptoms. Also, many a times he would try to distract himself and avoid these thoughts through movies, music, etc. So paradoxically, they were also increasing the symptoms. So these were some of the cognitive appraisals that we identified in the patient. So once he told us, there is a possibility that my sperm is there in urine. Hence, I may have impregnated the lady who used the toilet after me. So here, there is an abnormal estimation of a risk, which is called overestimation of threat. Then another thing was, having sexual thought means that I'm a bad person. So here, he is equating a thought, an obsessional thought, with a real behavior, which is thought action fusion moral. This is yet another example of the same. Image of my mother came into my mind when I masturbated. Hence, this means that I'm having sexual thoughts about her and I'm a bad person. So that is thought action fusion moral again. I must never have this kind of thought. He's trying to make everything perfect. I can't let myself be anxious. He has a lot of he has a lot of exaggerated threats about anxiety. So which is perfectionism as well as intolerance of anxiety. I must ensure that the thoughts don't become frequent. Here he is trying excessively to control those thoughts, which is mental control. So all these were the cognitive appraisals that we identified in the patient. For the thought action fusion as well as for the overestimation of threat, we used Socratic questioning as well as the downward arrow technique. This is an example of one of the downward arrow technique conversations which we had. So he told us, when I sit near a woman, I feel anxious. So we explored more into that. I feel that my sperms may go into the vagina. We asked how that may happen. He told, there is this bench on which both of them are sitting. So my sperms may actually swim through this bench and they may impregnate her. And it would be so wrong if something like that happens. So through open questions, we were able to make him understand that he is actually overestimating the threat. So we asked him not to get up and go. If the thought like this comes into his mind, he has to sit there. And slowly he tried to, he could surpass this anxiety. Here is yet another example. After I urinate, I feel so anxious if a woman uses the toilet later on. So then we asked what happens. So he told, my sperms are there in the toilet bowl, water bucket, etc. And so I feel that these sperms may impregnate the woman. It would be so wrong if something like that happens. So again, we could make him understand that this is actually an overestimation. There is thought-action fusion and all that. We asked him not to avoid going to toilet if a lady is bound to use that afterwards. Then regarding this mental control, we gave this little behavioral experiment for him. We asked him not to think about a white bear for 2 minutes. He has to tap on the table if the thought of white bear comes into his mind. He found that harder he tried not to think about the white bear, the more these thoughts would come into his mind. So this helped him understand that the harder he tries to suppress those thoughts and take control of them, the more difficult it would become. Then regarding the correction of intolerance to anxiety, he had a lot of overestimated threats regarding anxiety. So for this, we asked a number of open questions like what the worst thing is about feeling anxious, which sensation bothered him the most, were you afraid that anxiety would cause something to you, what did you do to reduce your anxiety, how effective was it? So through this, we could correct the overestimation of anxiety and some of the assumptions regarding anxiety. Towards the later parts of CBT, we could identify some dysfunctional beliefs related to social anxiety. For example, there was a steel bangle that he had. So he used to be quite afraid of wearing them. He used to avoid wearing that steel bangle in public because he always thought that everybody was negatively evaluating him and people would look at these steel bangle and assume some things about him. So we tried to correct those dysfunctional thoughts. We asked him to wear that steel bangle for one whole day. And then he found that the people are not actually so bothered about him, or they are not actually noticing these things as much as he thought so. And also we did psychoeducation for the family members so that there is no accommodation or expressed emotion, so that we could control all these factors and help in the recovery of the patient. So the outcome was that the patient's Y-box score dropped to 9. We continued CBT as well as the medications, and the patient reached remission. Thank you.
Thank you, Dr. Sreya. Kashyapi?
Yes, ma'am. Ma'am, we'll be taking the questions at the end. So we will continue and invite a second chairperson for the evening. And so, ma'am, if you have any remarks or the comments about the case, then you can share. Right?
So I think we can go forward with your plan. No problem.
Okay.
Dr. Sreya, you can stop sharing your screen.
Okay, yeah, I'm trying to. Is it okay now?
Yes.
Okay, thank you.
So I would like to invite a second chairperson for the evening, Dr. Smita Deshpande, ma'am. She's a professor and head of department at the RML Hospital, New Delhi. She was during 2014 to 2018. She has led over 36 research projects related to autism, schizophrenia, clinical trials, psychological aspects of mental health, disability.
Muted.
Okay, thank you. She has more than 300 publications in national and international journals, and she is a member of the editorial board of several national and international journals with high impact factors, the Biological Psychiatry, Online, the Psychiatry Research, the Asian Journal of Psychiatry, and the British Medical Journal of Psychiatry. And in 2022, she was declared as the thought leader by the Psychiatry Research. And she has participated in the developing the Indian scale of assessment of autism, recognized by the Government of India for the nationwide certification of disability of autism. Ma'am has also co-authored the tobacco cessation guidelines for the governments of India, Montenegro, and Kazakhstan. And ma'am is also the member of several ethics committee and ICMR, CSIR, and DST projects in the review committees. And she was the member of the subject expert committee of the DCGI, CDSCO India, and for nearly a decade. The ma'am is the co-chair of the sections on the genetics of the World Psychiatric Association, and she is also the international WHO trainer and expert and the consultant for tobacco cessation, and visited several countries to train their trainers. So it is an honor and a privilege to invite ma'am, and she has accepted our offer to be the chairperson of this evening.
Thank you so much, Kashyapi, for the introduction. And I wish we could have kept it very, very brief, but you insisted on a slide, so I had to go for that. It's in my turn. It's a pleasure to introduce Janardhan Reddy. Janardhan, I've known Janardhan for I think since you were at least a senior resident, if not before that. Yeah. And he's been a leader in OCD practically from the day he took over as faculty at NIMHANS. He's had his entire career at NIMHANS, and he's done a number of path-breaking works at NIMHANS itself. He's received a number of international awards, apart from, of course, awards from various Indian Psychiatric Societies. He was a visiting Commonwealth Research Fellow at Oxford University way back in 1999. He's a Wellcome Trust. He won the Wellcome Trust Travel Award in 2002. He won the Daniel Kappen Prize in 2005. And again, that was on OCD. So from his early days, he's been interested in OCD, and he has run the OCD clinic at NIMHANS now for decades. Importantly, he earned the C.V. Raman Young Scientist Award way back in 2011. And he's also an ISBD scholar of the International Society of Bipolar Disorders. He's won awards from the Indian Medical Association as well. So Janardhan, it's a pleasure to hear you as always. And please go ahead and start your presentation.
Thank you, madam. Thank you for the generous introduction. Can I share the slide?
Yes, sir.
Yes, sir, you can, sir.
Yeah, just a minute. Do I share? Okay. I'm not able to see the sharing thing.
It is in the middle, sir.
Try and click at the bottom. Has he been able? Yeah, I think you are one of the.
No, I'm not able to share here.
Yeah, you are not. Because I can't see your screen.
So there'll be a green icon.
Yeah, now it has come. Now it has come. Yeah. Some problem in sharing is your screen sharing is paused. I don't know why. Can you see now? No. I'm not sure what the problem is, but it says your screen sharing is paused.
You can see the screen, sir, but.
So if you could email it to either Kashyapi or
Yes,
Nihal.
Yeah, that's what. But yeah. But I can. Fine. I will do that now. I think it'll be easy. I think I will email it to the same email ID I received the slides. Okay.
Sure, sir.
You have sent now. Got it?
No, it's not yet, sir.
But I'm still not able to understand why I'm not able to share.
We are able to see your screen, sir, but.
So if you could put it on the PowerPoint mode, maybe then we'll be able to see it.
Yeah, it's in the PowerPoint mode only now, but it says now.
So this is not PowerPoint. This is probably.
Now the screen has left.
Wait.
So we have received it. We are sharing it shortly.
Okay.
So we have 294 participants with us, hoping to reach 300 within few minutes. All right, sir, here we go.
Okay, I will be able to manage my slides on my own, or I have to keep asking you?
So we'll change.
Yes, sir.
That's not great. Anyway, so I can't change the slides myself, right?
Yes, sir.
Let me try 1 minute. Okay, let me start, although I don't like somebody else sharing my slides, but because I keep going back and forth. Good evening, everyone. Today I will speak on comorbidities in obsessive compulsive disorder. Comorbidities in obsessive compulsive disorder in some way is not a new topic. It has been a topic that is discussed for a very, very long time. But I think in the context of today's case presentation, where the patient had comorbid social anxiety disorder, I don't know, possibly GAD as well, this particular discussion probably is important. Now, before I start talking about the comorbidities, let me quickly say a few words about OCD in general. It's a highly prevalent disorder with a current prevalence rate of about 1% and a lifetime prevalence rate of 2.5%. This is a summary of various epidemiological studies. I'm not really quoting any particular study. It has a bimodal onset with a peak in the pre-adolescent period, maybe around 10, 11 years, and the second peak early adulthood. This is a very well-known bimodal onset of OCD. And when we say juvenile onset OCD, we often mean both pediatric and adolescent onset OCD. Now, OCD, despite there being very effective treatments in the form of cognitive behavior therapy involving exposure response prevention and a range of psychopharmacological options, it still tends to run a chronic course. It's quite chronic in the vaccine waning course. Although some of the naturalistic studies recently do show high rates of remission, including studies from our center, but nonetheless, the relapse rates are high. And OCD is one of those disorders where treatment resistance is common. Sometimes as much as 40 to 50% of the patient show treatment resistance. And even in those people who have responded to treatment, symptoms tend to persist and they don't necessarily recover, but oftentimes there's a remission. And OCD is associated with a significant impairment in functioning, disability, there is marked disability, and what's often not realized is that there's a high suicide risk and a poor quality of life. Now, it is a general background for OCD. Let me go to the next slide. Next slide, please. Okay. Now, before I talk about comorbidities, I need to emphasize one important change in the status of anxiety, in the status of OCD in the current classification system, that is the DSM-5 and S11. Now, it has moved from the anxiety disorder section to OCRDs. That is, I think, one significant conceptual change, the way we understand OCD and related disorders. But we all know it overlaps with both anxiety and spectrum disorders. For example, anxiety disorder comorbidity is quite common in OCD. And both anxiety disorders and OCD respond equally well to SSRIs and CBT. But despite that, it is moved from anxiety disorder section to a separate section called OCRDs. Why did that happen? Now, there is an increasing realization that anxiety is not the core of OCD, is a compulsive is the core of OCD. So it's the repetitive behaviors is the core of OCD. So therefore, they are clubbed together all those disorders where repetitive behaviors are the core. So sometimes therefore you also find disorders such as trichotillomania and skin picking disorders where there are no oppositions but there are repetitive behaviors. And another important thing is that not all patients do report of anxiety when they have intrusions. Many times there is an excessive disgust sensitivity, gestalt phenomena, sense of incompleteness, and those are the kind of other symptoms that you often find in OCD and not necessarily always anxiety. So because of all these reasons, I think and phenomenological similarity to other repetitive behaviors in other disorders, it was clubbed together under OCRDs. But most important, according to me, is that increasing evidence of corticosteatothalamocortical circuitry being involved in OCD, whereas in anxiety disorders, primarily fear circuitry involving amygdala and prefrontal cortex. But in any case, recent research also shows involvement of limbic structures in OCD as well. So the traditional CSTC model also is being expanded to include many other circuits in the brain. And of course, OCRDs have a familial relationship, bidirectional. Patients with OCDs have higher rates of other comorbidities, other OCRDs in their families, and vice versa. And at least for some OCRDs, treatment response are similar. For example, the so-called cognitive OCRDs, such as OCD, BDD, olfactory reflex disorder, hypochondriasis, there is an obsessional preoccupation, and these disorders tend to respond to SSRIs and CBT, whereas body focused behaviors, hoarding, they don't seem to respond that well to classical CBT and to SSRI. So there's a bit of background about this conceptual shift in the way we understand OCD. Next slide, please. Yeah. Now, so when we say that they're all clubbed together, so all these 5 disorders, it's OCD, or dysmorphic disorder, hypochondriasis in ST11, olfactory reference disorder in ST11, and then you have the other disorders that I spoke about. We also spoke about bidirectional comorbidity, but how common are obsessive compulsive spectrum disorders in our samples? Now, this is a report that we published way back in 2003 when we systematically examined using a structure into a schedule the prevalence of obsessive compulsive spectrum disorders in those patients with OCD. We have around 231 patients and 200 controls. You will see that some disorders are more common in OCD than controls. For example, chronic tic disorders, Tourette syndrome, hypochondriasis, tic disorder, and other disorders. But in general, the overall rates, for example, although any tic disorder is about 39%, Tourette syndrome is just about 3%. Similarly, the rates of hypochondriasis were a little higher, but then BDD were very low. So overall, the other impulse control disorders such as compulsive buying, sexual compulsions, pathological gambling, kleptomania, all these are considered to be OCD spectrum disorders and often described as common comorbid conditions in OCD, but in our sample, we hardly found anything. Similarly, there are very, very low rates of eating disorders. I just want you to keep this particular data in mind. I don't think this data has changed a lot in the last 20 years that I've been running OCD clinic, because when you looked at the prevalence of comorbidities in our larger sample of 2,000 patients, I don't think the rates of OCD spectrum disorders are much higher even today. Next slide, please. Now, we subsequently examined this sample of 545 patients in our OCD clinic who have been examined using structure interview schedules. Now, this number has gone on to 2,000, but I just keep the representative thing because we are not published the later part of it, but the figures are pretty much similar. You will see that about 60% of the people, 57% had a comorbidity. Major depression and ischemia were the common comorbid disorders. Anxiety disorders were found in about 21%, and social phobia was a common comorbid anxiety disorders compared to GAD and other disorders. And you will see very low rates of any OCD spectrum disorders including tic disorder. Tourette syndrome is rates are very, very low. This is despite the fact that we specifically ask for these disorders and patients are being worked up in detail. So in a sense, it shows that comorbid anxiety and depression are common compared to the other disorders which are supposed to have an etiological relationship with OCD. Okay, next slide, please. Now look at this particular figure. This is a data from the National Comorbid Survey replication. We wrote one review article in Nature Review Disease Primers a couple of years ago, and we actually used the data from this particular National Comorbid Survey to demonstrate how common comorbid disorders are in OCD. Now, this particular figure is a revelation because it's very, very different from what I presented from the OCD clinic sample of NIMHANS. You will see that substance abuse disorders themselves account to about 30 to 40% of the sample, whereas in our samples, we rarely see substance abuse disorder when we diagnose OCD. ADHD is present in over 20% of the people, and you will see that any impulse control disorder is present in up to 60% of the sample. Mood disorders in over 60%, and anxiety disorders in general is present in about 75%. So very, very high rates of comorbidities in the particular survey. So there is a great discrepancy in the comorbid rates across centers, probably across geographical regions. The reason I am presenting this is to highlight this particular fact because I presented the data from our clinic in the previous two slides. Next slide, please. Now, this is a systematic review and meta-analysis of all the clinic-based studies published by my colleague Isha Sharma and others 2 years ago in Frontiers, where they reviewed at least about 100 studies in this meta-analysis, and each study had at least 100, n of 100, so that sample size is good enough to really identify various comorbid conditions. And in this particular figure, you will see that comorbidity in general was present in about 64% of the people, and mood disorder, any mood disorder for that matter, is about 40 plus, not really more than that, like you saw in the previous picture. In that, major depressive disorder and dysthymia were the common disorders. The bipolar disorders were not all that common, and you will see anxiety disorders in about 25% of the patient population, and then you will also see subcategories of various anxiety disorders. Now, it's also interesting in this particular meta-analysis that personality disorders are present in about 30% of the population. Now, I must actually mention, when people report on comorbid disorders, there is often a tendency not to really report on personality disorders. So we really have very little data when you really look at them. Similarly, you will find that the studies don't report much on autism spectrum disorders, ADHD, substance use disorders. You also don't find studies reporting on impulse control disorders. The focus is usually on what can be quickly diagnosed using SCID1, where focus is mainly on anxiety and depressive disorders. So sometimes the low rates in some of the studies may be a function of how we actually ascertain patients and how we evaluate them. So just keep this in mind. So even in this study also, mood and anxiety disorders are the commonest, but you also find personality disorders very prominently displayed, and you don't really see much of a substance abuse here, I guess, not as much as at least here in the National Comorbid Survey revised version. Next slide, please. And this slide, in this slide, we also compared comorbid rates between pediatric OCD sample and OCD samples. Here again, overall psychiatric comorbid rates were very similar, but then major depressive disorder was more common. In general, depressive disorders are more common in adults, whereas in children, it was more of anxiety disorders. And surprisingly, in this particular study, you find almost similar rates of tic disorders and ADHD. This is a surprising finding for me because you often talk about children with OCD having more of ADHD, tic disorders, ODD, and conduct disorders. But in this meta-analysis, strangely, tic disorders and ADHD are almost similar in both adult and pediatric samples. Next slide, please. So, in general, if I have to sum up, common comorbidities are mood disorders, anxiety disorders, neurodevelopmental disorders, particularly in children, which actually includes ADHD, autism spectrum disorders, and tic disorders, eating disorders, obsessive compulsive and related disorders, substance abuse disorders, at least in some studies, Maybe in community studies, you find more of substance abuse than in clinical sample. I'll come back why that is the case. Then often talked about by clinicians, but not really highlighted in any articles on the comorbidities is a comorbid psychosis and bipolar disorder, because these two disorders pose a huge challenge in managing an already difficult illness with SSRIs and CBT. So the bottom line is that while comorbidity is common, the rates seem to vary very highly across studies. Next slide, please. So why does this happen? One is, of course, we all know the rates can vary a lot depending upon the study design. What we reported earlier in that meta-analysis are mainly lifetime rates, but study designs also contribute. And another important reason why there can be variation in the comorbid rates is because how you actually ascertain patient. The clinical samples generally tend to have higher rates of comorbidity because patients with more severe illness and more comorbid disorders, they tend to gravitate towards clinical sample in clinics and tertiary care centers, and you obviously find higher rates of comorbid conditions. For example, I'm not going into detail. For example, there are some centers in America where comorbid rates of ADHD have been very, very high in pediatric OCD samples, but in the community samples, you don't really find such a very high rates, although the rates higher than in the general population. Whereas in the community-based studies, you will find more of substance abuse and alcohol in OCD patients and less of other disorders, possibly because people with OCD use alcohol and substances to overcome their anxiety, and they are more often picked in the community, whereas in the clinical sample, you find with more severe illnesses who have other comorbid conditions. Then, of course, there are measurement variations, how you diagnose them, what instrument you use, who diagnoses them, whether it's done by lay interviewers or clinicians. All those also matter in assessing the rates. Then the social demographics of the sample can vary a lot. And then, of course, I'm sure there must be some variations in etiophysiological loads of various genetic, neurobiological, and environmental factors which contribute to varying rates. So I think I want people to keep this in mind, that variety of factors contribute to varying rates of comorbid conditions in clinical samples that we come across. Next slide, please. Now, I will come back to this a little later because I think this slide, next slide, please. Next slide. Yeah. No, the previous one. Yeah. Now, I'm trying to now examine what is the relationship between various clinical characteristics and symptom and comorbidity. Let us start with symptom dimensions. The commonly known symptom dimensions are, go back to previous slide. Commonly known symptom dimensions are contamination dimension, harm and aggression related dimensions. Then you have sexual and religious thoughts. Then symmetry, ordering is one dimension. Of course, hoarding is now not part of OCD. Now, sometimes harm-related symptoms and unacceptable taboo thoughts are combined into one group called taboo thoughts. Then you have contamination, then you have symmetry symptoms. Now, and then there are, of course, associated obsession and compulsion. Now, do these individual symptom dimensions have any specific correlation with comorbidities? Next slide, please. There is some data to show that if you have harm and aggression related thoughts, you are more likely to have also other disorders such as PTSD, suppression anxiety disorders, and impulse control disorders. In essence, more of anxiety disorders and impulse control disorders. Whereas if you have a taboo thoughts, you are more likely to have mood and anxiety disorders, somatoform disorders, and tic disorders. Whereas contamination dimension seems to have more of comorbid with hypochondriasis. So sometimes symptom dimensions can also perhaps determine what kind of comorbid disorders you have. And if you have thoughts predominantly in the domain of ordering, symmetry, then more likely to have comorbid conditions such as ADHD and tic disorders. Next slide, please. So that's about symptom dimension comorbidity. What is the effect of age? Now, in children with OCD, anxiety disorders are more common than depressive disorders. They're more common in adults, perhaps due to a shared temperamental and developmental vulnerability. And then there is a lot of data other than the meta-analysis that I showed, where you found similar rates of neurodevelopmental disorders in adults and children, but there is enough data to also suggest that neurodevelopmental disorders are more common in children. In fact, ADHD, OCD, tic disorders, VDD, these are the kind of combinations you see when you actually see younger children with OCD. Whereas in adults, you will find more of mood disorders, substance use disorders, particularly in clinical samples, and also you find more of personal disorders, perhaps because very young children, it's very difficult to diagnose personal disorders, but as you see them as adults, you will also see more of personal disorders. And what is also unique here is that in children, anxiety disorders sometimes start first and then OCD develops later on, whereas in adults, mood disorders, particularly depression, seems to be the consequence of OCD in adults, whereas including substance abuse disorder, whereas in children, there doesn't seem to be so much of a correlation of OCD resulting in anxiety, unlike OCD resulting in depression. This is something that we need to keep in mind. So many mood disorders in adults are secondary to OCD. Perhaps it may not apply to bipolar disorder other than SRI-induced switches. Next slide, please. Yeah. So there is also some work on whether initial symptoms in some way determine the development of distinctive lifetime trajectories of comorbid conditions. Now, this is the article which was published about a decade ago. If you see a patient with OCD now, who actually first presented to separation anxiety disorder, then you are more likely to develop multiple anxiety disorders, somatoforms, partisan depression. Whereas if your OCD patient started off with ADHD, then you are more likely to diagnose comorbidities such as SUD, that is substance use disorder, and of course, this kind of comorbidity is associated with worsening course of illness. Then if you present with tics, because tics often tend to antedate the development of OCD. OCD comes much later. You have ADHD, you have tics, and then you develop actually OCD. Some of them, if are unfortunate, develop bipolar disorder in that long range of neurodevelopmental disorders. So if you present with tics, then more likely you also have comorbid body dysmorphic disorder, skin picking, and also trichotillomania. So what does it suggest is that if these kind of clinical presentations are seen, then you perhaps might have to focus more on identifying other comorbid disorders, or at least be more sensitive to pick up some of these disorders, which in a routine clinical workup, we may actually miss them. Next slide, please. Okay, so what is the chronology of comorbidities then? In 80% of the patients with OCD, anxiety disorders predate OCD. That was something point I was trying to say earlier. Whereas OCD is equally likely to begin before or after mood disorder. And in about 90% of patients, OCD began after impulse control. For example, if you have a skin picking, if you have a hair pulling, then or a buying or some other kind of impulse control disorder, they seem to antedate OCD development. OCD develops much later. That means OCD develops after anxiety disorders and impulse control disorder, whereas mood disorder, it is more likely to begin before or after mood disorder. And substance abuse, of course, after development of OCD in about 60%. Now, these percentages vary across studies. I'm quoting from this National Comorbid Survey replication. But in general, if you diagnose OCD, and if you also diagnose anxiety disorders, you often find that they have, for example, in the case that was presented, I don't know, but many times they may not report social anxiety, but they might report APD and other kind of similar kind of problems much before the onset of OCD. So this is something that we need to keep in mind. Next slide, please. Now, what is the effect of comorbidity on the clinical presentation? For example, this one comorbidity, tics, which has for example, a specifier in DSM-5, OCD with and without tic disorder. Now, that specifier is basically because this particular comorbidity is a very unique comorbidity, unlike other comorbidities. In fact, there's a suggestion that some forms of OCD may be actually a variant expression of Tourette syndrome, and therefore they have some unique clinical features. For example, if you have an young adolescent, young person with tics and also OCD, they are likely to report much earlier onset of OCD. There's a male predominance, and they have more of sensory phenomena. For example, what do I mean by sensory phenomena? Not just at experiences, sense of incompleteness, and sometimes even physical sensation which precede compulsions are more common in those who have OCD plus tics. They also often are comorbid with ADHD. They are more of aggression, harm-related obsessions and less of contamination obsessions. There is a greater family tree of OCD and tic disorders, and they generally tend to respond poorer, not so well to treatment with SSRIs. Now, so this obviously makes this particular combination a sort of a combination which predicts somewhat poorer course of illness, but also perhaps you might want to manage these children differently. Particularly, for example, you might want to think of adding a small dose of antipsychotic when you want to use SSRIs, or if tic disorders are prominent, you might also want to use habit reversal techniques and not just expose response function for OCD. So the management of this particular comorbidity requires a special attention, and therefore I think I'm emphasizing this point. Next slide, please. Now, one more disorder which is often undiagnosed in OCD because we really don't ask is autism spectrum disorders. Now, one thing we need to remember is there is sort of phenomenological overlap between the repetitive behaviors in autism spectrum disorders and OCD. Autism spectrum disorders often is characterized by stereotyped movements that are ego-syntonic, whereas the repetitive behaviors in OCD are often ego-dystonic. The intense preoccupations or fixations and topics of a particular desire or interest are more common in ASD, and they tend to be ego-syntonic and at times enjoyable. And of course, you also find social communicative deficits which begin very early in those with ASD. It's a different matter altogether. ASD and OCD can co-occur as well. So what is not clear is that whether SSRIs are beneficial in treating OCD and OCD-like behaviors in ASD. We really don't know. They're not really so much of a data. But generally, presence of autism spectrum disorder in a patient with OCD poses various challenges in management and may be associated with poorer outcome if ASD is not really attended to, and we actually sort of tweak the treatments based on the presence of diagnosis of ASD.
One day food that every 10 is already positive.
Next slide, please. So we spoke so much about the impact of about the comorbid depression, anxiety, and OCD. Now, strangely enough, presence of comorbid anxiety disorders does not seem to substantially affect the course of OCD treatment, although having multiple problems might add to more disability and poorer quality of life and greater suffering. But then anxiety disorders by themselves don't seem to substantially affect the course of OCD treatment, whereas depression, when in severe form, actually may interfere with the ability to engage patient in ERP. That's one thing, but also it may prevent habituation in when you do expose response prevention. Now, whether depression by itself contributes to poor treatment outcome there is a conflicting literature, but generally most of the patients with OCD who have depression is often understood as a consequence of OCD. So when OCD improves, depression also tends to improve, but severe depression perhaps if it is present, if it is not handled separately, then ERP may not be all that successful. So that's very important that we need to keep in mind. In fact, if you look at the older literature on OCD, often, particularly the people who wrote about CBT in OCD, kept emphasizing that if there is a patient with severe depression, first treat depression. What do they mean by treat depression? Give clomipramine or some other antidepressant, treat depression, and then you can do CBT effectively. Of course, we have moved on from that situation right now. But anyway, this is something that used to be talked about very, very frequently in the past. Next slide, please. Now, I mentioned in the one of the earlier slides that personality disorders rates are fairly high in OCD. OCPD is the most common comorbid personality disorder, followed by AAPD, that is anxious avoidant personality disorder, schizotypal and borderline. Schizotypal disorder in particular seems to be associated with a poorer treatment response, and many people suggest adding a low dose antipsychotic when schizotypal personality disorder is present. But the literature in general on the effect of comorbid personality disorders, the outcome is quite sparse, including that on borderline personality disorder. I will cover in the next slide what does OCPD do, because OCPD is the most common comorbid diagnosis. Next slide, please. Now, what does OCPD do to OCD? Now, when OCPD is present along with OCD, you also realize that they may have had younger onset of OCD. Perhaps OCD is more severe with more disability, and OCPD often contributes to poorer insight in OCD. And these kind of patients tend to have more of symmetry, ordering, exactness, sense of incompleteness, not just right experiences and holding as symptoms, but less of contamination or other kind of symptoms such as taboo thoughts. Now, there seems to be some evidence that presence of OCPD does contribute to poorer response to CBT or ERP. So perhaps OCPD may have to be parallelly dealt with when OCPD is severe, otherwise outcome may not be successful. Now, the naturalistic prospective follow-up studies of OCD, I'm not talking about treatment trials with CBT and SSRIs, but naturalistic prospective follow-up studies. One of them is mentioned here by Eisen et al. 2006 and 2013. They did a long-term follow-up studies up to 5 years. Now, we also had a similar kind of a naturalistic follow-up studies. We all found that OCPD is associated with lower rates of response remission over a period of time, and also high rates of relapse. So that's something which is come up in 2-3 naturalistic follow-up studies. So we need to keep this in mind when we treat OCD patients. Next slide, please. Now I come to comorbid with schizophrenia and bipolar disorder. I'm not covering everything in great detail because I just thought we can leave some time for discussion. OCD symptoms in schizophrenia. Now, lifetime risk is about 1/3 of the patients somehow develop, somewhere during the course of the illness, develop OCD symptoms. And then about 12 to 14% of them have OCD, diagnosable OCD. I'm talking about schizophrenia patients in the longitudinal course versus the lifetime prevalence of 1 to 3% in general population. So obviously, schizophrenia patients have much higher rate of OCD symptoms and also OCD as well. Okay, and there is some evidence that the prevalence is much more in chronic schizophrenia. I really don't know how much of this also is related to chronic treatment with atypical antipsychotics, particularly clozapine. On the other hand, risk of psychosis in OCD is very low. There's about less than 2%. We have also done similar kind of studies in our population at NIMHANS. So generally, we found similar rates of psychosis, similar rates of OCD and schizophrenia. Next slide, please. So what is the relationship between OCD symptoms, OCD and schizophrenia? Now, OCD is, some people say it as a risk factor for psychosis. I don't know how much it is true, but generally, if you have a diagnosis of OCD, in the long run, your chance of developing a schizophrenia, schizoaffective disorder, or for that matter, bipolar disorder is about 10 to 12 times more than in general population. That is, if you have a diagnosis of OCD. I don't know whether I have a slide on that, but there's a huge Swedish study is published from their database that OCD is a risk factor for psychosis. Now, it is also possible sometimes OCD symptoms can be part of a prodrome, or they can be commonly seen symptoms in first episode psychosis, schizophrenia, and what I spoke about in the course of long-standing chronic schizophrenia, also OCD symptoms can develop. And recently, there are a lot of literature on atypical antipsychotics causing OCD symptoms. So OCD symptoms can be of various types in terms of their role, both as a risk factor, as a prodrome, or just as a symptom of an illness in the early part of psychosis, or patients can develop OCD symptoms during the long-term course of the illness. Some of them could actually be atypical antipsychotic induced. Next slide, please. Okay, so what does presence of OCD on schizophrenia mean? Now, there are conflicting studies. In first episode patients, there is some data that may actually be protective against positive and negative symptoms. That means that if you have first episode schizophrenia patients with comorbid OCD, there is some data to show that intensity of positive and negative symptoms are lower. But most studies talk about in the long run, presence of OCD contributes to greater positive and negative symptoms, earlier onset of psychosis, you have a longer duration of illness, it results in frequent hospitalization, they have poorer neurocognitive performance. But let me tell you, we did one neuropsychological study we published a couple of years ago. Presence of OCD plus schizophrenia versus schizophrenia alone, there was no difference in neurocognitive performance at all. And there is also a possibility of higher rate of attitude disorders, depression, and social behaviors, and both are comorbid. The greater functional impairment. So generally, many people believe that OCD imparts poor prognosis to schizophrenia. Now, if you're taking an examination, the best answer to give is perhaps when OCD is present along with schizophrenia, prognosis is not all that great. Most people agree with that. But let me tell you, it's not all that very clear. Next slide, please. Now, second generation antipsychotics cause OCD symptoms. Most of them are with second generation drugs. Clozapine is the culprit. Rates of OCD symptoms are higher with clozapine. Of course, there are also reports with respect on olanzapine, but best evidence for clozapine. In fact, rates vary from 10 to 70%. There are very few case reports with other atypical antipsychotics. In fact, some people recommend aripiprazole to treat OCD symptoms in the context of schizophrenia. And mostly, first generation antipsychotics seem to be safe in terms of their association with OCD symptoms. Next slide, please. No, next. Yeah. Now, let me come back to the bipolar disorder. Now, if you look at the pooled prevalence, OCD in bipolar disorders is about 17%, whereas BD in OCD is about 18%. This is the pooled data from the meta-analysis, and also you can also see that OCD comorbidity, that comorbidity is more in bipolar 2 than in bipolar 1. And overall, if you look at the other way around, OCD in bipolar disorder is about 21%. So we actually examined this systematically in our OCD clinic. I don't know whether I have a slide. Next slide, please. Yeah. Now, this is something that we published some years ago. We wanted to look at what is the prevalence of bipolar disorder in patients with a primary diagnosis of OCD who attend our OCD clinic. Now, the rates were actually very low, contrary to popular belief and also what the literature says. Actually, in our sample, not more than 4% of them actually had a bipolar disorder. Of them, one was two of them were a switch, and only one had a bipolar 1 disorder. And then altogether, the rates are very, very low, which is actually quite reassuring to think that SRIs don't seem to really cause so much of switch or induce bipolarity, because all these patients were on SSRIs. Next slide, please. So, but when they do exist together, the OCD tends to run an episodic course with worsening during depression and remission during mania. There's a higher propensity for a switch, and then there's a higher family loading for a mood disorders, and comorbid with anxiety disorder is higher, and also probably there's a greater suicidality. You look at the number of friends have quoted here. It obviously means that these are not very, very well proven findings, because it's very difficult to do studies on this kind of a comorbidity. But if I have to say highlight one aspect as comorbidity, that is, if you have OCD which is very episodic with almost near complete recovery in between, think of a mood disorder, particularly a bipolar disorder, and then inquire of our family history of mood disorders, because the treatment of such an episodic OCD, comorbid bipolar disorder, is much easier than treating OCD in the background of bipolar disorder, where OCD tends to persist even in between the episodes. Next slide, please. Okay, so what are the features which suggest underlying bipolarity in OCD? Of course, there has to be family loading for bipolar disorders, and if there is any evidence of switch with antidepressant and episodic course, like I mentioned, and improvement of symptoms with mood stabilizers and typical antipsychotics. All these things should make you think that you might be dealing with a primarily bipolar disorder and not so much OCD. And all experts emphasize that in such kind of patients, avoid giving SSRIs, stabilize the mood with atypical antipsychotics or mood stabilizers, then obviously OCD tends to remit. Next slide, please. So what are the challenges then in treating such a combination? Now, you often require a combination of multiple mood stabilizers and antipsychotics that increases the medication load. Now, SSRIs can cause a switch and worsen the course of BD. But then, unfortunately, while we all give SSRIs, and to treat OCD in the context of bipolar disorder, where OCD does not remit in between the episodes, SSRIs, but there's actually no data on the efficacy of SSRIs at all. whatever we do is basically extrapolation from the efficacy of SRI data in primary diagnosis of OCD. Okay. Now, if you have OCD in the context of schizophrenia, now if you can avoid clozapine, maybe addition of SRI and comprimine, CBT, all these are possibilities. But then keep in mind the pharmacokinetic interactions when you add SSRIs to clozapine. And then there are also some reports of psychosis worsening with clomipramine and SSRI. Just keep these things in mind. But all this data is from the anecdotal case series and individual case studies. You really don't find too much of systematic data. Okay. But of course, when there is a drug-induced OCD symptoms, obviously the management is much simpler. You reduce the dose, particularly if it is clozapine, change to another antipsychotic, preferably aripiprazole or amisulpride, or maybe even typicals. There are one or two studies talk about the utility of aripiprazole in treating OCD in such patients. Of course, I regularly use SSRIs in treating such patients with fair degree of success. But if you ask me to have a data on that, no systematic data. And CBT, you can think of if patient is cooperative for doing therapy, because many patients, psychotic symptoms remedy, but then taboo thoughts or contamination upset tend to trouble them. So in such situations, maybe we can treat OCD the same way as we treat primary OCD. So to summarize, in OCD, comorbidity is a rule rather than an exception. So therefore, detailed evaluation of comorbid condition is necessary because it may have an impact on the course of OCD. They need to be identified and treated. Psychosis and bipolar disorders, though not as common as depression and anxiety, they pose special challenges in the treatment. And pediatric associated OCD is associated with distinct comorbidities, and therefore, the pediatric OCD requires a different line of management. I've tried to cover what I think are common comorbid conditions that we actually see in the clinic. I have not touched upon many of the comorbid conditions, particularly OCRD, ADHD. There are a whole lot of conditions, but I thought we can just focus on those comorbidities which we regularly encounter in our practice. Thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir. Yeah. So I would hand over to the organizers for the question-answer session.
Yes, ma'am. Ma'am, if you have any comments.
No, this was something which I had always expected from Janardhan, a really in-depth analysis of the topic that he has been given. And I'm happy that he also spoke some things about his own work in this area. I'm sorry to see that, apart from his own papers or papers from NIMHANS, there doesn't seem to be too much of literature, Indian literature. And we all know that because OCD is OC symptoms or obsessions, I wouldn't say obsessions, maybe being very particular, is so common in the community that we don't know the outcomes. The type of patients that we see in our own clinics are very different even from center to center. And therefore, one wonders, whether it's a genuine difference or whether the whole thing is colored by, different environmental circumstances and so on. And now, over a period of time, as we age, we start thinking of the people in the community who don't come for treatment. We can certainly urge them to come for treatment, but what happens to them? How do they cope? Or is it that only the mild OCDs continue in society and the moderate and severe ones eventually find their way to a psychiatrist? So these are unanswered questions. I don't think any of us have answers to that. But I don't know, maybe Dr. Reddy can speak a little bit about it.
Madam, I think you have brought out two important issues about the treatment outcomes and course. I can tell our own example. When we started OCD clinic, this is about 25 years back, we used to see a lot of what I call them as garden variety OCD. They come, you diagnose them and you treat them. They often are not treated. In fact, 70% of our patients used to be drug naive, not even drug naive, they were treatment naive patients. we give them SSRI sensation because it's the easiest treatment to give. Even now, that is the first line treatment because you cannot offer give treatment of CBT, and SRS work. Now, we have done at least 4 or 5 naturalistic prospective studies. In fact, I started doing the study in children first, and then I've done at least 3 or 4 studies in adults with my colleagues. In all these studies, in fact, my colleague Dr. Isha Sharma published a meta-analysis in Journal of Clinical Psychiatry some years ago. The outcomes in our clinic were much higher. The outcome rates are much better than in American samples. For example, 70% of the patients had responded to treatment, have gone into some kind of remission in our sample, compared to much lower rates and high rates of relapse in other centers. Now, I cannot say that it is because we are from a different planet, but I think these are all drug-naive patients, untreated, low comorbid rates, better insights. So all those qualities that we associate with good outcome across all psychiatric disorders in any case. Now 25 years on, I only see 30 cases now. Every week I do rounds, there will be 15, 20 OCD patients. I often look at patients saying, can they come back and tell me I'm better this week? So what I'm saying is, if I do now prospective follow-up studies of our own samples, I think the outcomes may not be as great as it was 10, 15 years back. So the kind of samples we study, I think, seem to contribute to outcomes. But I think in the community, I agree with you that perhaps are milder patients, or patients who are amenable for treatment, who do not have severe illness, and they do well in the community samples. There are some studies of outcomes in community samples. They're really not really as bad as we really make it out to be. And then there is also a lot of talk about sub-threshold OCD itself contributing to a lot of, may not be as much disability as the clinical OCD, but then some degree of poor quality of life and distress. And there is not too much of a data on subclinical OCD in the community, but they are quite common because OCD symptoms are themselves very common in the community. So if you ask me, I think prognosis for OCD is really not as bad as it is made out to be. I have always talked about it. I think many patients do well simply with SSRIs, not even with CBT, and they perhaps have to be on treatment for a longer time. But then if you run a OCD clinic, you accumulate all bad cases.
Yes. So that's what I would like to point out to Sreya as well, that she spoke about, short-term outcomes, say 1 month, 2 months, 3 months, whatever, and be very cautious about following up this child because, this adolescent, because he began fairly early. And there are lots of family factors which are not very contributory to a good outcome. But I see that there are a lot of questions in the chat boxes, so I would hand over to, I think, Kashyapi or Nihal, whoever is going to handle the question.
Yes, ma'am. Before handling the questions, we would like some comments from Dr. Ruksheda, ma'am. Ma'am was the chairperson for the first session. So if she has any comment on the case.
Thank you so much, Samiksha. Glad you're here as well. Thank you so much, Dr. Janardhan. It's always lovely to hear from you, and so impressive with the body of work that you've done. I think not a single psychiatrist or mental health professional in India can say that we haven't learned something about OCD from you. So thank you so much for that, and you'll continue to inspire us all with your dedication, especially in the field of OCD. So that kind of single-minded attention to a particular topic is also something that I think a lot of us should follow. I know we all end up doing a lot of general psychiatry, but there's a lot to say for something like this as well. So thank you so much for that. And Dr. Smita, ma'am, of course, her comments are always very to the point and very, very pertinent, and gives us a lot of food for thought as well. And she's already mentioned a couple of points to Dr. Sreya, who did an amazing job of presenting a case as well. As far as questions or even comments for that matter is concerned, I would just maybe, Sreya, speak a little slowly next time. You have enough time. Don't worry about it. We all want to hear a little bit more from you. So don't worry about it. Even if you go a few seconds or a couple of minutes over your time, nobody's going to penalize you. It's not an award session. Don't worry about it. But of course, the way you described the case and the way you did the case formulation was also very, very well done. But yes, what we do, like, backing up with what Dr. Smita Deshpande ma'am also said, that we want to keep a look at this person, right? We want to keep, especially when somebody presents with any kind of symptomatology as a teenage, in their adolescent age group, even if there are a lot of symptoms directing towards a particular phenomenology, we do understand that this is an evolving brain, and this is the neurodevelopmental and the neuroendocrinal changes. And of course, the social factors are also going to impact certain symptoms in this way or that. So, as far as possible, I always work with the working diagnosis with adolescent than just kind of, going ahead and saying it. We do, of course, do a lot of psychoeducation and explaining what we are doing with the child, and to the family caregivers, or even schools or colleges when required, so that they understand these are symptoms that we are working on, and these are ways that we are working on the symptom, and not focus too much on a diagnosis, because also at that age there's also a lot of labeling that goes ahead with it. So to take care of that would also be important. And there's always family history, and like how Dr. Janardhan was also saying, that the family history, especially even if not like of OCD as such, but OCPD is also something that we definitely want to keep an eye out. And we do see a lot of kind of blurred lines between OCD, psychosis. So a lot of the times we do end up diagnosing as psycho-obsessive disorders as such. So that's something that we need to kind of focus on as well. And again, psychoeducation, insight orientation is one of the mainstays of how you would begin a treatment plan, because you may formulate a great treatment plan, but unless and until you cross that first barrier, you're not going to be able to implement it. So with that, I'm going to stop my monologue and hand it over to Kashyapi. And there are a lot of questions, and we have a lot of eager people. And I think Smita
just one remark, Shreya, your slides were beautiful. I was very impressed with them. But the transitions take time. So if you are very pressed for time, then maybe it's a good idea to transition from one slide to another. Otherwise, the presentation was very good.
I just need to say one thing. Is okay? Yeah.
Yes, sir.
Sreya actually made a very good presentation, but I just want to make two observations. One is that I really commend her for having done CBT for this patient, because tendency to give it another SRI and send the patient away. So there's good work, and I'm sure that must have contributed to improvement, because patient is already an SSRI. Second observation, I will not go into details about CBT, but second observation is that I think this patient was on a multiple medications combination. I was not very sure about the rationale. For example, adding high dose of clomipramine to already pre-existing clomipramine, then adding risperidone, then adding CBT, all of them being done simultaneously. I would probably have done simply, if I really wanted to do CBT, I would have either optimized fluoxamine, or maybe take off fluoxamine and give clomipramine in a proper dose, and maybe do CBT, a fantastic combination, rather than having 2, 3. Now you have difficulty in withdrawing clomipramine and fluoxamine because you have them together. You have also had risperidone. We really don't know what contributed to the outcome. Hopefully it is CBT. So there's one observation I thought, and the combination of fluoxamine and clomipramine can be quite dangerous.
Yes.
Yeah, particularly in the doses that you have employed, 125 or 150 milligrams. That's one observation. I think some of the examples they gave for thought action fusion and other cognitive dysfunctional beliefs in OCD, I'm not exactly sure they were the best examples for thought action fusion. Maybe you can go back and check some of those things, but I really appreciate your effort.
Thank you for your comment, sir. Do you want to say something, or should we go ahead with the questions?
I think we can go ahead with questions.
All right. The questions I have divided into two parts. The first one is related to the psychopathology of it. So there's one important question from Dr. Niharika. She's asking that she has seen a lot of girls with contamination OCD having a history of sexual abuse in past. and the content of thoughts were directed about bodily fluids a lot of time. In such cases, should we work on trauma first, or we should go ahead with offering therapy for OCD? If we do treat OCD first, do we have to still work on trauma eventually to get better outcomes with OCD? Sir, if you can take the question, sir.
Yes, yes. OCD, for whatever presumed etiology, the treatment package is same. Okay, but then the way you deal with perhaps changes. Now, I am not very sure. We know that there is a increased incidence of adverse childhood experience in those with OCD, and this also is true for many other psychiatric disorders. I would treat this patient with OCD who has contamination obsessions just as the way I treat any other OCD patient, maybe even with SSRIs, but then that does not probably the end of it, because if there is sexual abuse, and if that requires separate attention, it needs to be given attention in therapy, sexual abuse related complication therapy. But then I may not want to really link these two in terms of therapy delivery, because the ERP or belief modification based ERP or habituation based ERP, they are uniform across all OCD patients irrespective of these kind of histories. So I'll still go ahead with CBT plus SRI, but then if sexual abuse and its effects are obvious and prominent, I think there is we need to parallelly do therapy for that part as well. I would look at it that way.
Thank you, sir. I hope, Dr. Niharika, that answers your question. There's another question by Dr. Anil Kumar. He's asking if, sir, you can throw some light on religious scrupulously and relationship obsessions.
What do you mean by relationship obsession? I don't know.
Okay, so
that is, I think, a late term. I have not clearly understood, but in any case, scrupulosity, OCD, earlier people thought religious obsessions are common in certain religions. People with who are highly religious are people belonging to certain religions. Now, over a period of time, most people don't really think there is a case. For example, people used to think that people belonging to Islam and Christianity or Jews, they have higher rates of sexual obsessions. But the kind of patients we see today in our clinic, there are so many people with Hindu religion, other religions have very, very prominent sexual obsessions. So I'm not very sure that religion is related to OCD, but it is possible, there is some evidence that people who are religious, that is a very different thing. Perhaps if they do develop OCD, they may have religious obsessions. That's not the same as a particular religion making you more prone to develop OCD. I think we should get this point very clear. Now, the point number 2 is, of course, CBT in people with scrupulosity has to be modified because there is a lot of guilt and shame associated with religious obsessions. I often don't do the kind of therapy that Sreya did if they are religious obsessions, sexual obsessions, because what a classical CBT does, Sreya, is it normalizes obsessions. What do you mean by normalizing obsessions? That all of us get random sexual thoughts, all of us get religious thoughts, all of us get thoughts of harm, but these intrusions, these normal intrusions become obsessions because of your appraisal. And what is that appraisal? It could be exaggerated perception, it could be inflated self-responsibility or beliefs about control of thoughts. Your appraisal of normal intrusions is what makes it obsessions, or the meaning you make out of it. Okay. Now, I find it very difficult in Indian patient to say that it is okay to have sexual obsessions about goddess Lakshmi and Saraswati. Normal people can have intrusions about. It's very, very difficult. Or for that matter, you can have occasionally people can have sexual thoughts about mothers and sisters. I think I would not do that. Although there is enough evidence to say that sexual intrusions are very common in general public. But then I personally prefer other way of saying it. Look, this is an OCD. Okay, these are symptoms of OCD. You are not responsible for these thoughts. That actually, I tend to give a biological attribution to these kind of thoughts, and it removes a sense of a guilt and a shame associated with these obsessions. But nonetheless, these are symptoms of illness, just like you have symptoms of typhoid fever. If I get OCD, I may also get sexual obsessions. And this is because of whatever biology. I tend to spend some time, and then I put it as a medical brain disorder. Therefore, you have these thoughts, and they persist in your mind because you are interpreting these thoughts as indicative of your character, when actually they are actually indicative of an illness. I take a different stance altogether. Of course, this is something that I've done over a period of years by my experience. There is no systematic literature on this, but I find myself very difficult to normalize these kind of obsessions. Harm-related obsession is possible to normalize. For example, I keep telling patients, you might feel like throwing your child off the balcony. Sometimes when you're angry, people accept it. Yes, I understand that. I sometimes get a feeling that I may get some disease by not washing hands. You can normalize them. But we should be careful when we normalize an obsession, because it can be quite difficult. But then this is very widely practiced in Europe and other countries where they follow classical Beckian model of CBT. Okay, and then I remember some time back last year, I actually presented in one of the online programs how to manage religious or sclerosis, OCD. I have PowerPoint slides. If somebody wants it, just email me. I'll send them some slides. There is one entire talk on management of religious OCD.
Oh, that would be lovely for the audience, sir.
Okay.
But another question from Dr. JP Agarwal. He wants to know what is the best pharmacological management of patients of OCD with bipolar disorder, and role of SSRI in such patients.
Okay.
I think that's a difficult to manage for all of us.
Yeah, the first thing is I use SSRIs cautiously. But if there is a very typical episodic OCD where OCD manifests during depressive episodes only, and not so much in manic or hypomanic episode, and in between the episodes the symptoms are very minimal or absent, I don't touch SSRIs. I think of managing bipolar disorder because we are managing episode specific OCD symptoms. They could and then if there is a family history of bipolar disorder, then all the more episodic OCD could simply be a manifestation of a mood disorder. So all over the world, people agree that such patients should be first managed mood stabilizers. But then that is a very nice story that we want to hear. But many patients have OCD symptoms to disabling extent even between the episodes also. That means they have a long-standing OCD. In the background of OCD also develop bipolar disorder. Now, if it is feasible, offer them CBT. If that is not feasible, then I think there should be an adequate coverage with a good dose of mood stabilizers, maybe even with an antipsychotic, and then use judiciously SSRI. And I've done it for many patients. It works, but then there is always a possibility of a switch. But it may not be really that high, actually, as we think, particularly when there is a good dose of mood stabilizer and atypical antipsychotic. Incidentally, we published a study on treatment of antidepressant in bipolar disorder in New England Journal of Medicine 1 or 2 months back. We found very, very low rates of switch in the open label phase and double blind phase. SSRIs, in fact, did not really worsen the course of bipolar disorder as we thought. I mean, I'm just saying it as an aside because we are all very scared of using SSRIs, but then always under the cover of mood stabilizers.
Sir, is there any preference for the SSRI, fluoxamine or fluoxetine or anything else when if the person of OCD switches to mania?
Not really, but then if you are giving multiple drugs, I would prefer escitalopram or sertraline because drug interactions are less. Otherwise, you'll have to worry about drug levels of other drug levels increasing, particularly with the fluoxetine, fluoxamine. But whereas sertraline and escitalopram have less drug interactions. But whether any particular SSRI causes more switch than the others, there is no evidence. But definitely, clomipramine tricyclic, yes, and venlafaxine are more likely to cause a switch than an SSRI.
Okay. So there are 2-3 questions on a similar topic. How to address SSRI-induced sexual dysfunction in someone with a good response to high-dose SSRI for OCD? Are there any evidence for drug like metazapine, trazodone, vortioxetine in such cases?
Well, it's a very difficult scenario. Nobody has a perfect answer. Now, what is generally done in the management of OCD is that we don't reduce the dose from high dose to low dose. The dose that gets you well is the dose that keeps you well. If 60 milligram fluoxetine and helped in remission, then don't reduce it. That's a standard thing. But then if the sexual side effects are very, very prominent, I would try to reduce the dose to a minimum effective dose. It may be 40 milligram or not 80 milligram of fluoxetine. Now, this can be tried. Okay. And there are times when with long-acting drugs such as fluoxetine, you can even practice, or with other SRIs, you can practice weekend holidays. Saturday, Sunday, you don't have to take an SRI. Then, it might be okay for sexual functioning, and maybe use of bupropion, ciprofloxacin, and other drugs, maybe even sildenafil when required. But there is no perfect answer to this. Reducing the dose is an option, but if the person responds to high dose of SRI only, then I think you have to think of all these other medication options. None of them are fantastic options, but then there's no harm in trying them. Mirtazapine, I don't know. Yes, I mean, they're all very, kind of evidence is not great. There is some evidence that vilazodone perhaps may not cause so much of sexual side effects, but then there is an SSRI, but then there is no trial of vilazodone in OCD as of now, but I have tried in a couple of patients. It's a challenge, but but since such patients, think of CBT also. If I've got a couple of patients, I also struggle to find the right balance.
Okay, so another question related to the recent advances, if about your experience in use of ketamine, memantine in OCD, and I would also like to ask about RTMS, the high frequency coil, which has been recently approved by FDA. So, what is your experience in these three things, sir?
Okay, ketamine. I'll start with ketamine. Ketamine is a better antidepressant than an anti-OCD medicine. Okay, there is a lot of literature on ketamine's efficacy in treating depression. Now, OCD, there is one randomized control trial of ketamine, single dose ketamine in drug-free OCD patients from New York, done by one of my collaborators, Blair Simpson and their group. Sometime back, they reported good improvement with a single dose of ketamine itself. I don't think they really extended the study later on. But we have published one case series of about 14 patients where we gave ketamine like an ACT, 5 doses. Okay, 5 doses, thrice 5 to 6 doses of ketamine, like ACT schedule. Now, in this 14 or 15 patients, 2-3 of them, I don't know, they really improved dramatically with ketamine. The rest of them, ketamine did not have any effect at all. Now, after that experience, we have also given ketamine to several patients. They do not improve. Right now, we are struggling to get funding for a good ketamine study and identifying the biomarkers for the last 1 year. I'm not finding a funder who can do a big study. In fact, there's a protocol ready with us. We have been approaching various people to do that ketamine's efficacy in OCD. But I think I would not rate it very high from the existing evidence. Ketamine need not be oversold. That is my, because I always look for evidence first rather than, because these are very peripheral treatments. But then you can consider them when nothing else works, obviously. Because some people seem to improve. Why they improve, I don't know. Who improves, I don't know. But the literature is sparse. The next question is about memantine. There's a lot of literature on memantine in OCD. Most of these studies come from one geographical area. That is my concern. I don't want to say where they come from. All of their studies are very positive pharmacological trials. So I'm a little skeptical what really happens. But my own clinical experience, memantine is not great. But then there are people who say that they have found benefit with memantine. It can be tried as an augmenting agent because it's a molecule with less side effects, and there is a lot of literature on glutamatergic drugs being useful in OCD. But then I don't know. I don't want to sound I am a person who believes in talking on evidence base, but I must say that I'm not so enthusiastic about the efficacy of memantine, although I use it, because after some time you don't have too many options for OCD. But not a great augmenting agent. I wouldn't rate that. Third one is TMS. Now, TMS, numerous meta-analysis systematic reviews, they all seem to show, including one from my group, they all seem to demonstrate that TMS is effective in a proportion of patients. Perhaps with deep TMS, the success rates are better. There's one large study which led to FDA approval. But then they administered deep TMS with symptom provocation. Okay. Now, recently, I mean, as late as just 2-3 days back, my colleagues from Netherlands with whom I do some collaborative work, they published a study on RTMS plus CRP versus ARP alone, sham RTMS, all that randomized control trial. RTMS did not, all groups improved. So they couldn't really conclude whether RTMS really was helpful. So my point is RTMS is very popular because for whatever reasons, easy to administer, we can charge them, and then we all look for somatic treatments, we give them. No harm. There is evidence that RTMS works in a proportion of patients. I think we can use it. But then in the long run, RTMS has no solutions. We are looking to manage patients in the long run. So once RTMS course over, how long the benefits persist? 1 month, 2 months, 3 months at the most. So that is a real problem. But I think there is a place to study whether RTMS can augment response to ARP. I think that's where the real interest is. And then there are so many protocols now for RTMS. And then which site? Earlier, people used to talk about supplementary motor area. Now they're all talking about transfrontal prefrontal cortex. It's an area which is emerging, but you can use it. I also use it. But I also have that skepticism in my when I use it.
Okay, sir. We have answered it at length. So there's one common theme of question regarding the schizophrenia and OCD. So what can you explain about the nosological status of schizo-obsessive disorder? And another question related to this is, if a patient of schizophrenia has OCD symptoms, or if it's schizo-obsessive, if we start SSRI, will it worsen the psychosis? Or if both are present simultaneously, which should be treated first?
Well, there is no evidence that actually antidepressant worsen psychosis. I mean, Madam can answer this question better than me. There's no evidence. Earlier, when tricyclics were used, there used to be some kind of literature saying tricyclic antidepressant can worsen psychosis, but I don't think there is not really a lot of evidence about that. So you can use SSRIs in schizophrenia patients much more liberally than you can use in a patient with bipolar disorder. That much I can say. And from my clinical experience, they seem to work. Okay. Now, which one to treat first? That liberty is not there. Schizophrenia is schizophrenia. Both are equal. Like I said, if schizophrenia, psychotic symptoms are prominent, treat psychosis first. If OCD symptoms are minimal, of course, we don't have to really struggle to treat them. But many patients, both are equally prominent. Then you have to use an antipsychotic plus an SSRI. There is no option at all. Earlier, I remember when we were residents, we used to be told, we used to follow a typical Fowles hierarchy. If you have schizophrenia and if you have anxiety symptoms, those symptoms, everything can be subsumed under schizophrenia. So give an antipsychotic, everything else will go away. Now we have realized over a period of time it doesn't happen. Okay, each symptom complex has to be treated separately, unfortunately. So if both are prominent, treat both of them equally. That's how I look at it. I think I answered one question. I forgot what are the two questions.
So regarding the treatment only, you have answered all the three, sir.
Okay, then fine.
So actually, the problem with us, the recent generation, we have not heard the words like Fowles hierarchy. It is from your generation, and everybody seen it up from NIMHANS have often used this term. So we often get confused because lately the synopsis which we are reading is not mentioning about it. So I think
because it has gone out of fashion. Now the tendency is to help you to diagnose as many comorbid conditions possible, not because they exist in reality, but at least helps you to manage them. Otherwise, you are unlikely to manage those symptom complexes. So the current American classification system encourages you to do as many comorbid conditions possible, whereas earlier the tendency was to explain everything with one diagnosis. Now that has changed over a period of time. I mean, not knowing it doesn't really make much difference. But then if the symptoms are there, we need to treat them.
Just last one question from Dr. Pawan Tiwari is there any role of ECT in OCD?
My answer is clearly no at this point of time, unless you have very severe depression, which on its own necessitates ECT. Let me end this by saying there is an article in Psychiatry Research sometime last year, from China. They gave 36 ECTs to patients. And it was a positive study. We discussed in our journal club. I was really shocked to read that report, how we managed to get published in, I think it was not Psychiatrist in JAD. I'm not very sure. We have written a long rebuttal, which will get published very soon, because that article is clearly supports the benefit of ECT, but it was to our mind, there are lots of methodological issues, and nobody gives 36 ECTs mean numbers. So there are lots of issues, including statistical analysis. So I'm just warning people, because the study is published, and of course there is a rebuttal which is going to come very soon in the journal. I don't see a role for ECT, but if you ask me, sir, is there a randomized control trial to show that it does not work? We're saying it does not work. Answer is no. No.
What if the schizo-obsessive, will it work, sir? Any role in that?
Schizo-obsessive?
Yes, sir.
Even though schizophrenia symptoms may improve, but I don't think OCD symptoms will improve with ECT. I mean, in general speaking, see, there are exceptions to all rules, okay? Because we are after all treating disorders whose biology or vulnerabilities we don't know. So you will always find some patients where, out of frustration, you've done everything, your ECT patient improved, and then you give for 10 other people, they don't improve. So there are exceptions. There are occasional patients who respond, but then those occasional anecdotal experiences are difficult to interpret and then recommend as guidelines for routine treatment. So if you want a perfect answer, then you have to, since ECT is very widely used with OCD, I know in India it is very widely used. I think there's a case for a good large randomized control study to examine whether it really works and settle the story once for all. But then it's very, very difficult to do this kind of studies, because then you have to have a sham ECT and all those kind of issues. But from whatever we know till now, I would not really rate it as a treatment for OCD. So also lithium. Somewhere I saw lithium also.
So there's a repeat question. If you allow, can I ask?
Please, please.
Yes, sir. Does culture or surrounding play a role in evolution of OCS or OCD? How culture is related to phenomenology of OCD? If there is a relation, are there any primordial or primary prevention strategy for people with family history of OCD? From Dr. Shankalal.
Yeah. Now, culture perhaps can shape the content of obsession, but OCD is one illness. If you look at the clinical profile of OCD from many parts of the world, it's a fairly secular disease. It manifests similarly across cultures, across geographical region. It's just that your kind of sexual obsessions may differ depending upon your religion. And I see many Hindu patients come with sexual obsessions about goddesses. I mean, it's obviously influenced by what religion you practice. In some other religion, it could be something else. Okay, but then I'm not sure of anything else other than the description of earlier descriptions about the relationship between the phenomenology of OCD and the religiosity and religion, which I answered earlier. The second one is second part of that is what you said. The question I forgot that.
Any relation? So, is there any relation, or are there any primordial or primary prevention strategy for people with history of OCD?
No, I think people are now talking about staging of OCD like they're talking about staging of bipolar disorder very in the nascent form. But then, if there's heavy loading for OCD in the family, then obviously, catch them early if they develop symptoms and treat them. And there is a strategy that's being employed for all psychiatric disorders. But then I think there's a very, very little really work. But then there is some literature that, like in schizophrenia, even in OCD also, long duration of untreated illness can have poorer outcomes. So shorter duration of illness has a better outcome. So if you do find in such situations, if there is heavy family loading, then perhaps one need to be alert and cautious and offer treatment at the earliest. I'm not aware of any preventive strategies for OCD. No.
Thank you, sir. One repeat question, if you allow, sir.
Yeah, please.
It would be, so basic difference of CBT in children versus adult in relation to OCD.
Well, it has to be developmentally sensitive protocol. I mean, there are very well described protocols, but the fundamentals remain the same. But then you need to keep the children's age in mind and then appropriately administer CBT. But let me tell you, CBT wherever, with whomever you do, ERP is the most active component. Even if you use cognitive techniques, you cannot do away with ERP. Okay. For example, I think John March's book on pediatric OCD CBT manual is a very, very widely used manual. It's just that how you deliver it changes. Yes, it has to be developmental sensitive, but the principles are same. And there's a topic for discussion separately, CBT in children.
Yes, sir. So I just had one query regarding the autism and OCD, which you mentioned earlier. Regarding the stereotypical behavior which is there, and sometimes autistic people are not very verbose about their thought process. What do you say if about the children who are having autism and we're not able to diagnose OCD, but we see very high symptoms which are very repetitive in nature? So, how will we approach that case, sir?
Well, that's what I mentioned in my slide. We don't know how well SSRIs work. Okay. But
Yes, sir.
if you think there is so much of obsessionality to these symptoms, which anyway is the case even when you don't diagnose OCD, because there are a lot of preoccupation I talked about. They may be useful, but how useful they are, we don't know. But when they have a classical OCD symptoms, then perhaps they are useful. Like I said, ASD plus OCD is not an unusual comorbidity. Okay, but primarily ASD symptoms, which look like compulsions because of the repetitive nature, how will they respond to SSRIs? I don't know. And I must also mention, I don't see such population so much in my clinical practice because children are seen by somebody else. I must say that my experience is very limited in treating ASD plus OCD combination.
Okay. Thank you, sir. So with everybody, sir, thank you so much for being here and giving a wonderful, wonderful presentation and taking up the question so patiently. Thank you so much, chairpersons. If there is any comment, final comment from anyone from the chairperson.
Just a comment for deep appreciation for Janardhan, of course.
Thank you, madam. And I must say that Sreya made a good presentation. Although she was fast, she did a good presentation. I'm impressed that she actually presented CBT work rather than just presenting
Yes.
that's a good thing.
Over to you, Nihal.
Thank you, Samiksha. Next, we are conducting a workshop this day on December 9th and 10th by Dr. Salman Akhtar, already like 150 limited delegates. We already closed the registrations now, but we are just telling everybody who are in the webinar to know that we are conducting a psychotherapy workshop. That's it. Thank you to Janardhan Reddy sir for accepting accepting talk in our YPS case box series. Thank you Smita ma'am for being a chairperson, as well as Ruksheda ma'am for being a wonderful chairperson for today. And thank you Sreya for your wonderful case presentation. Thank you very much.
Thank you. Good night. Take care.
Thank you, sir.
Thank you. Good night.
Good night.
Good night. Goodbye.